Hello and welcome to the Great Birth Rebellion podcast, where we grapple with current research to help you get the best out of your pregnancy, birth and postpartum journey while still challenging the dominant birth culture. I'm your host, Dr. Melanie Jackson at Melanie the Midwife, and I'm joined weekly by my co-host B from Core and Floor Restore, and this is the Great Birth Rebellion. Gorgeous. All right. Welcome everybody to episode 19 of the Great Birth Rebellion. We're joined by Nigel Lee, who is a researcher. Are you from Queensland, Nigel?
Yes. Yep. From a number of other places, but currently in Queensland, yes.
And where are we? Episode 19. We want to discuss the perineal bundle today, and people might not have heard about that, but it's all going to be revealed. Nigel, you're one of B's research crushes. I don't know a lot about you personally. Can you give us...
My husband doesn't know I'm on this podcast with you today, because I think if he did, he'd be petrified that I'm going to sign up for my PhD, which we've already been emailing about, but he doesn't know. Yeah, Nigel's going to be my PhD supervisor, and my husband doesn't listen to this podcast, so it's fine. I've just said that he has to be, because his work is in line with everything that I love. And if anyone's ever seen Nigel present, he has this incredible way of presenting evidence, but also using humour, which is what I like to do as well. So, yeah, we're going to be a great team. My husband just doesn't know about it yet.
So B wants to do a PhD with Nigel. So could you give us a brief introduction to yourself? Because I feel like you keep a low profile, but you've done some pretty amazing stuff.
Well, firstly, I'm a midwife, and I've been a midwife for quite a long time. Did my training in the mid-'80s and worked a lot predominantly in birth suites, but around sort of regional New South Wales and Victoria, and then went overseas and did a stint working in the UK as a midwife. What they call a fairly small hospital, but it did around about sort of 3,000 or 4,000 births a year, and worked there as a practice development midwife, and again predominantly on the birth suite, and then came back to Australia and worked in Brisbane as a team leader on the birth suite at the Mater Hospital, which is Australia's largest maternity hospital. We did about 10,000 births a year, half public, half private. And I was there for about 15 years before completing a PhD around sterile water injections. And that was kind of part of a sort of a transition plan, kind of a semi-retirement plan to move into academia. The retirement bit being no nights and weekends off, which was nice. It was getting a bit old for the night shift, to get a bit old and grumpy on nights. So I thought, no, I've got to do something about this.
So you did a PhD in sterile water injections.
Yep.
How old were you at that point?
Oh, good grief. Like a lot of midwives, I came to research fairly late. So I was in my early 50s when I finished my PhD, because we'd had the Queensland floods about the same time that we'd kind of finished data collection. So
amazing. That's inspiring for a lot of midwives, I think, actually. So then from your PhD, what happened then?
Then I got a job with the University of Queensland as a midwifery lecturer, stroke sort of researcher, and continued to do sort of my research on that. And then the last sort of 18 months, I've been fortunate enough to be in a research-only position, and recently picked up an NHMRC investigator grant, which means that it'll hopefully fund me my research for the next few years.
Well, they are lucrative, those grants.
Yeah, well done you. That's phenomenal. Congratulations. That's huge.
Yes, they're pretty competitive. So there aren't a lot of midwives that get them. So I was pretty happy to pick that up.
Yeah, that's amazing.
Go you. Yeah, Nigel is very much like the silent achiever in midwifery, and you just kind of you're at a conference, and he's like the Where's Wally, kind of like just appears and you see him and then he's gone again. Like I spent the last conference being like, where's Nigel? I need to find him. I need to talk to him. But yeah, you are the silent achiever, but you're doing incredible work. So let's dive into it today. We are going to talk about something that if you're pregnant, you need to know about, and if you're a midwife, you need to know about. So this really applies to everybody. We're going to dive into the evidence of what is called the perineal bundle. So Nigel, do you want to explain it to everyone listening today? What is it?
Well, the perineal bundle is something that has been around for quite some time in various guises in various countries. The WHO, which I remember stands for Women's Hospitals Australia or something along that lines, decided that they, put out the idea that there was a bit of a crisis in terms of maternity care in terms of severe perineal injury. And certainly, this is something that we would all like to do something about. But interestingly, the numbers in terms of severe perineal injury haven't really increased since 2011. But yes, it'd be good good to do something about it. It has a significant impact upon women's health after birth, particularly in terms of not ongoing sexual health, but ramifications for any current births or any subsequent births. And so they were looking at ways of sort of putting together a bundle to try and reduce this. We've always had this kind of conversation primarily around sort of the hands-off, hands-poised approach to birth, and the bundles overseas that were developed initially in sort of Scandinavia were very focused on the sort of a hands-on approach, which is a fairly sort of traditional approach, despite the fact that many midwives use a hands-poised. The hands-poised is really the hands-on. Hands-off and hands-poised tends to go together, whether you put your hand on the fetal head and the perineum or whether you just kind of have your hands there ready in case you think it needs it. Whereas the hands-on kind of obligates the midwife to apply that pressure to the baby's head and try and sort of pinch the perineum together to stop it from tearing.
Yeah, okay.
So that's a big part of the bundle. The other parts of the bundle are the position which when the woman gives birth in needs to be such a position that the midwife can actually visualize the perineum adequately. The problem with that is that invariably it's a supine position. So realistically, you've got to have the woman on her back to visualize the perineum in that respect and certainly apply the hands-on approach as opposed to...
Why not all fours? Because if you really want to see a perineum during birth, all fours is one of the greatest positions to see it because you can see everything and the anus.
Yeah, look, it's a great position to visualize perineum. It's a really awkward position to try and apply the hands-on position because now instead of going like this, you now kind of got your arm around between her thighs trying to grab the head and you've got the perineum like that, and she's probably moving around a bit more.
The position is all for the midwife's comfort in this, or the care provider's comfort, because it's not just midwives that have to do this, it's doctors as well. So
exactly.
We're talking about positioning for midwives' comfort so that they can be the most comfortable and apply the pressure in the most efficient way.
Yes. And one of the studies we did, we saw that the midwives who applied the hands-on approach, women in that group gave birth about 98% of them gave birth on their back, as opposed to midwives who didn't. We had many more women who were giving birth in upright positions when the hands-on approach was not used.
Okay, so we can just talk about this for a second, because birthing on your back came in to maternity care. It was an intervention that was commenced with what we believe was King Louis the something, who wanted to watch one of his mistresses give birth. And so he would not, at the time, the midwives were catching babies, they would be on the ground, and the birthing person, the woman, would be either in a squat or leant over. And so the midwife had to be on the ground. Kings don't grovel. They don't get on the ground. They're not peasants. And so the mistress gave birth on a bed so that he could watch it from his superior height of standing or seated on a chair. And then everybody Instagrammed it and found out what the queen or the mistress did, and it became really popular. And this is what happens. This is cultural, right? This is what happens in birthing. So what happened was the rest of the women in the court wanted to birth on their backs. And there's documentation from that time where midwives report more labour dyssocia, so birth slowing down, and more birth complications and they put it down to the position because that's the only thing that had changed. But that has stayed with us. And then if you look at how we watch birth in movies and TVs, typically the person's on their back. Often, I've birthed twice. I cannot imagine getting on my back. I remember the first time I gave birth, my body just instinctively bended me forward. And I was like, how do women do this on their back? So from the research, we know, right, that birthing on the back, people report it as less comfortable. What else do we know about birthing on the back?
Well, as you say, it's what they call it. It's not a sacral-free position. So you're talking about that, we've got all these wonderful hormones that produce during pregnancy that help soften the ligaments around the pelvis, do provide that little bit of extra flex and malleability in the pelvis, which provides, as you're talking about, provides that extra centimetre or so of room as the baby's coming through. If you're lying on your back, then the sacrum gets pushed up, the coccyx gets pushed up. You don't get to use that little bit of extra room and malleability that's there. It certainly is. It's more painful. You're kind of pushing uphill.
Yeah, we don't lay down to poo, right?
No.
And everyone
says the same physiological mechanism.
It's exactly the same physiological mechanism. So, if you're asking a person to birth on their back, go ask yourself to lay down a poo and see how comfortable and successful you'll be. Yes, Melanie, what would you like to say? We mute each other, just so if you're new to this podcast, we mute each other and then we have to put our hands up when we want to talk. It's very regulated.
I don't like interrupting people. Can we just start from the very, very beginning of discussing there's 5 elements to the perineal bundle. And the idea is that these 5 elements are used together. Although I can see in the perineal bundle documentation that the Women's Healthcare Australasia group put together, that they've talked about, oh, it's not mandatory. Oh, you have to ask women if they want all these things. Oh, by the way, oh, this and that. But technically, a bundle is supposed to be used all together. So this Australian bundle that this group has created recommends the first element is warm compresses on the perineum. The second element is a slow controlled birth of the head, which involves that hands-on positioning that you talked about, where you cinch together the perineum and you apply a hand to the baby's head in an attempt to somehow protect the perineum. I'm using inverted commas, and slow the birth of the baby's head. Then the third element is they talk about the technique when performing an episiotomy. The fourth element is assessment of perineal tears, which involves putting your finger in every single woman's rectum post-birth to assess any rectal damage, even if there's no perineal tear. And then the fifth element is accurately grading the severity of perineal tears. So that's the bundle in a nutshell. And actually, anybody who wants to see the perineal bundle listed out with detail, I'm going to put the links up as well in all the documentation for the mailing list, and it will be underneath this in the show notes underneath this podcast episode. So
you've done a study that's looked at the perineal bundle.
Well, we did a study that looked at hands-off and directed pushing prior to. And this was just as the perineal bundle was being introduced. And then we did some qualitative work after a couple of years after the bundle had been introduced, looking at midwives' experiences of it being introduced because of the surveillance and the sort of mandatory parts of it, and also women's experiences. And what we found was basically, there are essentially 4 things that are probably, wrong or not great about the perineal bundle. First one is the evidence base behind it. So as Melanie is saying, one of the aspects is warm compresses to the perineum. And that's pretty well the only component of the perineal bundle that actually has any solid evidence base behind it. The others don't.
And so the warm compress evidence is that it decreases 3rd and 4th degree tears, which is the whole point of the perineal bundle, right? So the perineal bundle is to reduce tearing, but its aim is those what we classify as severe perineal tearing, which is 3rd and 4th degree tears. And for those that don't know, that's tearing into or through the anal sphincter, so part of it or all the way through it. So they came up with this bundle, but the only part of it that was actually evidence-based was the warm compress. So the other 4 elements weren't evidence-based when they were brought into the bundle.
No, they were not. No. So there's been a number of randomized trials that have looked at the hands-on versus hands poised and hands-off. They've never shown any difference in severe perineal tearing between those groups. So it doesn't seem to be, they're either equally as effective or equally as ineffective as each other in terms of reducing severe perineal tearing. The evidence behind the changes to episiotomy are pretty weak, but we have seen significant rises in rates of episiotomy in Australia since the bundle was introduced.
So before the bundle was introduced, am I right in saying that the evidence we had around episiotomies was that they should only be done if there is fetal distress, and performing one will increase or expedite the birth of the baby?
Yes, that's right. And the research that we did just prior to the bundle coming in, we looked at episiotomy rates in midwives who used a hands-on approach as opposed to those who used a hands-off or hands poised. And what we found that midwives who used a hands-on approach were 2.5 times more likely to cut an episiotomy than those who didn't. But the rates of severe perineal tearing did not differ between the two. So it was not making any impact. It was not being protective of reducing severe perineal tearing.
Mm-hmm. So there was no evidence that episiotomies reduced severe perineal tearing, but we put it into the bundle.
Yep.
Mm-hmm. And when we put it into the bundle, we got specific about them, didn't we? Like I've heard, I've not seen, but I've heard midwives talking about like protractors in the birth space to measure the angle of the mediolateral. So mediolateral meaning it's the angle that they're cut, right? So they're cut outwards away from the anal sphincter. So the whole belief around episiotomies is that if you create this artificial tear that goes away from the anus, then you're going to prevent tearing to the anus. That's the belief around them, but there is no evidence that has ever proved that.
No. Not in vaginal births. There's some, argument around forceps and vacuum births. They're really quite different because you're inserting something else into the vagina, so it creates extra room. Yeah,
but with vaginal births without instrument, no evidence that it decreases tears. But we put it into the bundle anyway. And did we get protractors? That's what I want to know.
There were anecdotes from that, and we know that some hospitals were using variations of protractors to help midwives gauge the angle of the episiotomy, because it changed from about sort of 30 to 40 degree angle from the perineum to about 60 degrees, which is really quite significant. It's almost like cutting sideways instead of angling down. And to assist them with that, there were a few protractors hanging around, and somebody sort of came up with the idea of maybe we can have a clear piece of plastic with a line drawn on it that we can put up against the woman's perineum, which has to be on her back again, of course. So then we know the angle, we can cut through the plastic and the perineum at the same time and get the angle correct.
And the bundle says these are the guidelines. It says when an episiotomy is indicated, it should be at a minimum of a 60-degree angle. And when I had a little look into that too,
there's a little bit. There's been a couple of small studies that have suggested, it might. One of the problems with cutting episiotomies was that it was a risk factor for third-degree tears, because you'd taken away the integrity of the perineum, and then there's the chance that the episiotomy would continue to tear through and down into the sphincter. So it was always highlighted as a risk factor. So the idea of changing the angle from sort of 30 to 40 degrees to 60 degrees was to reduce the chance of the tear continuing down and cutting through the anal sphincter. So all it really did was address the risk from cutting the episiotomy in the first place, as opposed to reducing the risk of third and fourth degree tears initially, which is why we never saw any real change.
And
so we've now got, sorry, I was saying, just to sum this up, right? We've now told people how to birth, but and told them what position to take, which we know is not evidence-based or comfortable, because I've never seen, and just so you know, to people listening, episiotomies are always cut with a person on their back. So if put you on your back to do the hands poise, we know that hands poise increases the risk of episiotomy. Oh, I keep saying hands poise. Hands on. Do you know why? Because I'm like, if your hands are poised, they're going to be on. Like, that's my thinking.
It's different.
I know, but that's like from a practical sense. I'm like, if you're poising them,
hands off.
It's very different.
Consider hands off and hands poised the same thing. Intention is hands off. If you need to do something, then you do something.
So anyway, to do hands on, you have to be on the back, and that increases the risk of episiotomy by 2.5%. So 2.5 times.
Yes.
What you saw. Right. So just to sum that up. Just so people are getting where we're getting to. That's all.
Yeah. The bundle was created because there's a 2 to 3% chance overall that a woman could have a third or fourth degree tear. And so the intention, noble as it was to reduce that 2 or 3%. However, now with this bundle, we've found ourselves in a situation where 1 in 4 women, so the recent Australian Women's data says that 23 to 24% of women are getting an episiotomy now in Australia.
Yes, yeah. So it's gone from about 18% up to about 24%, which is over a period of a couple of years, it's a fairly significant rise. And the one thing that's missing, of course, is any sort of longitudinal studies that have looked at the impact of increasing the angle to 60%, the ongoing sort of sexual health of women after giving birth and having these episiotomies.
The perineal bundle itself lacks the evidence to do the practice in the first place.
Oh, yes.
Right?
We take this opportunity to talk about how it was implemented, because there are claims that the bundle is, if you read any of Rachel Reed's stuff, who was very passionate about the perineal bundle, or what she affectionately calls the perineal bungle. The fact is that they created this bundle with, as you say, very little evidence. Most of the elements don't have evidence to support them in the bundle. And then they rolled it out to 28 hospitals in order to test it. And all of the training process was focused around training the health professionals in those hospitals to administer the bundle. But women weren't involved in the study in a sense that they weren't told they were part of a research project, and they didn't necessarily consent to be a part of it. Would that be right?
It was. In some respects, it was presented as a research project, but actually it wasn't. It was more of a sort of a quality improvement. So there was no sort of testing against another group that weren't getting it. But certainly in terms of there were a number of issues in the way that it was rolled out. And we did a study with midwives in terms of their experiences of this. And what we found was, because there was quite a bit of surveillance in the initial period after the rollout of the midwives to ensure they were using it. So there was a little checklist that they had to tick off, and there were people wandering around with clipboards in and out of the birthing rooms, making sure that they used the hot packs and applied their hands the way they should, and used all the elements of the bundle. So there was a lot of surveillance going on that would not normally occur within a sort of birthing environment, which of course put people in the birthing environment that would not normally be there. And we found that, probably about a third of midwives thought, okay, well, this is a reasonable idea. They were probably hands-on midwives in a way and thought, this is kind of using parts of my practice I would normally do. So that's okay. I'll kind of go along with that. And then there were about a third of midwives who thought, well, I'm being told I have to do it, that it's compulsory. The catch cry was every woman, every time. And so they were really just kind of, they may not necessarily agree with it, but they were just kind of compliant because it's, that's their job, and they didn't want to get moved off the birth suite if they weren't doing the right thing. And then probably a slightly less than a third number of midwives were, as we often are in these situations, looking at ways to get around it. And a number of those were quite successful, even in terms of, talking to women and sort of explaining and saying, okay, well, you actually have a choice. You can say no, or birthing women specifically in positions or in using water births as a means of sort of subverting some of the elements of the bundle itself.
But 4 of the 5 components weren't evidence-based. I just want to keep bringing people back to that. And this is where knowing the evidence behind practice, if you're a person birthing in the system, is really important, because this gives you the information. You may be listening to this going, this sounds great, I really want to have it. You may be listening to this going, I don't. And I think one of the biggest confronting factors for many of us midwives was the rectum examinations. And I think many people still don't know going to birth that is becoming, because the perineal bundle isn't in all hospitals, is it?
No, only those who are members of the WHA. Some hospitals have kind of picked up various elements of it.
So if you want to know if your hospital is doing this, you have to ask your care providers at your antenatal appointment. And so you can ask, does this hospital practice the perineal bundle or not, or elements of it, and speaking to them about, because you might be happy to have you might be happy to have the warm compress element, but you might not be happy to have the hands-on approach and episiotomy. Asking whether the rectal exam happens routinely at your hospital is also something you may want to know. So can we just explain that one, just so people actually understand why that was brought in and what's it meant to achieve? Well,
the rectal exam is supposed to determine whether a woman has had a third-degree tear or not, so whether there's an injury that's involved the anal sphincter. Sometimes these are and it's been quite common after a birth, if there's an existing tear there, that we check that tear to see whether it's actually involved the anal sphincter. And that's been routine practice for many, many years. And it's reasonable to do that. What this introduced, which was quite different, was actually doing rectal examinations on women who had intact perineum, so had no obvious or visible injury to the perineum at all. So the idea being that there may be some occult or some injury to the anal sphincter that you may not be able to see, but you might be able to feel if you put your finger in the woman's anus and actually had a good feel of the sphincter tissues themselves. So these are reasonably rare. Certainly they have implications for women when they're there. But the question is, if you find one, what are you going to do about it?
So what would be done about it? What's the purpose of trying to find it? Procedure done in theatres like a 3rd or 4th degree tear to find it, or is it just once you find it, you know about it, and it can't be healed?
That's the problem. They are so uncommon that we don't really have any practice guidance in terms of, okay, what do we do now? Do you actually undergo surgery and so it's back together? Do you wait and see if it heals of its own accord? Do you then go on and do further ultrasound studies to see if you can determine more accurately whether it's only involves a few fibers or whether it's completely through the sphincter itself, and what you do about that? So it's difficult to sort of say, okay, we do this assessment. If we're going to do this assessment, then maybe we should have figured out up before that what we're going to do about it once we've found it.
So the bundle did not advise. It just said, do the step, find it, but it doesn't advise what to do thereafter.
No.
So just because we if there is a tear there, we want to know if it's in the sphincter, if we can visibly see one. The issue that I have with this, and a lot of other midwives have with it personally, is that we're doing it when the perineum is intact, and then we don't know what to do with it afterwards. Well, I just want to offer here, just so you know, you might be like, yes, I want I want a finger into my anus after I've had my baby. If my perineum is intact, I'm happy to have that. I'm happy for it to be checked. Other people listening to this will be like, if it's intact, if my perineum is intact and there's no visible tearing to my anus or perineum, I do not want a finger inside my vagina. And this is your choice to make. You are allowed to make it. You're allowed to say yes or no to anything, especially you're allowed to say yes or no to someone sticking a finger into your ass.
And that's part of the problem. The research we did with women and their experience of the bundle brought up two issues. And the first one was that, we interviewed about 15, 20 women, and none of them were advised of the bundle during the antenatal period. So prior to the birth itself, there was no information prior to given to them. And then for a number of those women, when it came to the examination, the consent process was lacking. It was, often sort of, we need to do this exam. Is that okay with you? Without actually sort of specifically saying, actually, it's going to involve a vaginal and a rectal exam, even though your perineum is intact. So,
I'm just going to stick my finger into your anus now. And it happened without a pause or a question.
Yes, and sometimes that wasn't even raised. It was just, we need to check down below sort of thing to make sure you're okay. Is it all right? Yep. And then lo and behold, that involved a rectal exam they weren't kind of prepared for and certainly hadn't consented to.
And the idea of a rectal examination, because when this was introduced, I don't think midwives were routinely doing rectal examination. And so then we're all of a sudden told, okay, now you've got to check their bottom and their anus and see if there's any tears that have gone through there. I don't know about other midwives, but if they're so incredibly rare, most midwives don't know what this actually feels like on digital examination with their finger.
Well, they don't know what it feels like normally either. There's no comparison. I've never done a rectal examination as a midwife. It's not that we don't only know what that feels like, we also don't know what normal feels like post-birth, right? Is that what you're trying to get at too, Melanie?
Well, what I'm saying is that we've been told to assess the rectum, but like you said, we don't know what the usual integrity of the rectum is supposed to feel like because we're not used to routinely checking rectums. And then if we did find something, would we even have the capacity to recognize it with how rare it is?
Yeah, it's a good point. And I think, one of the points or recommendations the bundle does make is that two clinicians should be present when the perineum is being assessed to see if there's a severe perineal tearing there, which is, probably fair enough in terms of we're not very often very, very good at picking these up, as you say. But it doesn't really sort of specify, okay, what are the qualifications and the experience and training of these clinicians are. So for midwives who've done perineal suturing for some time, they'll probably have a reasonable idea of what a third and fourth degree feels like because they've done, perineal rectal exams are kind of a relatively routine part of undertaking perineal suturing. But for those younger midwives or those who are not trained in perineal suturing, then it's going to be quite difficult, say, to get an idea of what a third and fourth degree tear is going to feel like when the rest of the perineal tissue is intact.
Yeah. And so I'm looking down the list now of the elements of the perineal bundle. We've already decided, yes, warm compresses, good evidence. We can do that to reduce the incidence of third or fourth degree tears. And you can apply a warm compress with women in any position. I can vouch for that because we do it if women give birth on land in physiological positions at home. We've determined that element 2 of encouraging the slow controlled birth of the head with a hands-on approach doesn't have an overwhelming level of evidence to support this hands-on idea. And what compounds that issue is that when midwives adopt a hands-on approach, 98% of them are doing that with women in supine and lying on their back positions. And midwives, and as you said, midwives who are using a hands-on technique are 2 or 3 times more likely to cut an episiotomy. And so already element 2 is problematic. And then we're talking about techniques of performing episiotomies in element 3, which again, you said, really poor research for understanding what the best technique is for doing that. And we've then just poked holes in the assessment process that's included in the perineal bundle. And as you said too, episiotomy rates have gone up significantly since the perineal bundle's been increased. We're currently at about 23 or 24%. Has the bundle noticeably reduced the percentage of women having third or fourth degree tears from what you've seen?
That's a really good question. And the thing is, we don't know. So the WHA on their website produced some data from 2019, and they highlighted a 10% reduction in third and fourth degree tears amongst breast women. Now, that sounds great. The problem with that is we don't know whether that's raw data or whether it's been adjusted for things that will, normally cause greater risk of third and fourth degree tears, like large babies and that sort of thing. When we look at data from overseas, so in the UK, the Royal College of Obstetricians and College of Midwives introduced a very similar bundle across the UK, and they did a before and after study of just over 42,000 women, and they reported a 20% reduction. So they said they saw their rate drop from 3.3 down to 3%, and in terms of statistical analysis, that was barely statistically significant. It just kind of crept into that statistical significant range, and that was a 20% reduction. So if we're only seeing a 10% reduction, half of 20%, it's probably not going to be statistically significant. And that's relevant because when you say something's not statistically significant, what you're saying is that this can happen by chance, that there are a whole lot of other things that might be influencing it. So when you're seeing a 10% reduction, well, that might just be a kind of a rounding error or something that's occurred completely different to the bundle itself. We don't have the statistical, robust processes behind it to actually demonstrate that that's occurring. And the other thing is, okay, we've seen a 10% reduction. That doesn't kind of talk to the application of this bundle in the impact of the increasing episiotomies and giving birth on the back, etc., that's had upon the tens of thousands of women that the bundle has been applied to get a fairly minimal reduction in perineal tearing.
And the other thing that I suspect, and here's my presupposition about the findings, because their website really says that, so they put a number of 473 less women sustained a third or fourth degree tear as a result of the package. However, I'm wondering if they replace those third and fourth degree tears, so those 473 women who they say had a reduction, they've just replaced tears with episiotomies. And they haven't anywhere on the website or in their data reported on the episiotomy rate. They only keep reporting on the fact that there's been a reduction in third or fourth degree tears. But is it entirely possible that although they've reduced tears, they've done so because they increased episiotomies?
Yes. And the other thing is that what we don't know is how, because we know that episiotomies were actually a risk factor for third and fourth degree tears. So the idea was increasing the angle will reduce that risk factor. So how much of that reduction in third and fourth degree tears is associated with a change in the way that episiotomies has been cut and doesn't really have any sort of reflection on the other elements? I think another really sort of important thing to talk about in terms of effectiveness is that this is not the only bundle around. There are other bundles that are actually less prescriptive and also use a hands poised approach. And one of those is the Stomp bundle out of the UK. And they reported close to a 50% reduction in third and fourth degree tears by promoting birth in upright positions, using much better communication between midwives and women during that process to actually slow down the birth of the head, that pivotal moment, and no increase in episiotomy rates. Without all the prescriptive elements that we see in the Australian bundle, they were actually much more successful. So, if we were going to base this on evidence, why are we not using the Stomp bundle instead of the WHA one?
I would go one step further and go, why aren't we using all the aspects that we know actually reduce tearing, which is pelvic floor exercises during pregnancy, which is perineal massage. Doesn't just happen at birth. It has to be, I'd argue it's preconception, but it's that pregnancy. It's getting people to know their space. We have the evidence on what reduces tearing. And no, it's not always linked to third and fourth degree tearing. It's generalized perineal tearing, but we should be trying to reduce that as well and using that. And then my other issue with it is the long-term follow-up, and it's not just, we're just looking at one outcome. We're not looking at everything that surrounds that, like the emotional health, the long-term physical and emotional health that people experience. So,
yes, and I think the limited scope of the bundle is a really good point. It's it's very much about what clinicians do to women at a specific point in time, and the absence of any advice around antenatal perineal massage, which again is one of these few aspects that we actually have good evidence of that actually reduces all forms of perineal tearing. That wasn't included in the bundle itself. So it's kind of a, what we can do to women at that point in time sort of approach.
As opposed to holistic care. And so
yes.
People don't even know that they're in, that the bundle is going to be applied to them, and then there's no discussion around the perineum in antenatal care at all. And
so when you look at the bundle paperwork, it's all very lovely. They do a lot of lip service to, don't use this perineal bundle if women are in water. You can't apply the perineal bundle at all if a woman's in water. They talk about training clinicians to make sure that they educate women about the perineal bundle, and that they keep talking about in the documentation, this all has to be done with consent, because applying the perineal bundle is an intervention in the birth process. So we've got to understand that it's not just the unfolding of physiological birth, it's an intervention. But your study of the women that you did because I read your 2002 paper, none of the women reported being educated about the perineal bundle. They didn't know that they were receiving an intervention.
No, that's right. So the 15 old women that we interviewed, and they were from across various hospitals in Queensland, so it wasn't just one hospital. None of them reported it receiving any information antenatally, and very little information during birth itself regarding the perineal bundle. It was only when the elements were sort of being applied that some of them were actually approached and provided with, or consent was actually sought. And sometimes that wasn't. Consent during labour and birth is really tricky and often kind of fails the test for really informed consent. If someone's just given birth and you say to them, well, we're just going to check your perineum to see if you had a 3rd and 4th degree tear, and that involves a rectal exam, well, you need to kind of talk about that and the pros and cons and what are the alternatives, and provide someone with some time to sort of think about that, as opposed to, we're just going to do it because it's routine.
And that's the whole birth space, or that's the whole birth space in general, really.
So, Nigel, I was part of an ACM panel. I attended. I wasn't on the panel, but you were on the panel. And the ACM had invited 2 of the people who had created the perineal bundle, and you were there. And we were all there watching. There was a big turnout from memory.
It was, yes.
The ACM was pretty impressed, which tells you, I guess what we're trying to say is that perineal bundle is very controversial in the midwifery world, but also in the academic world. And I got the impression at that panel that the creators of the bundle were quite defensive, and they kind of refused to acknowledge that although their aim and intent in creating the bundle was wholesome and genuine, that they wanted to reduce 3rd and 4th degree tears, but they refused to admit that there was this unintended or unforeseeable consequence that it hasn't worked. The bundle hasn't worked in the way they intended. Can you see either on the horizon that there's going to be some actual research done on the effectiveness of the bundle, or is there a possibility that it will be dumped altogether based on the controversy around its application and implementation?
It'd be good to see some research around the implementation or the effectiveness of the bundle. That will always be done it can now only be done retrospectively because it wasn't introduced as a research proposal, which was unfortunate. They just kind of jumped straight into it. There are always limitations around retrospective studies and just how accurate they are. So collecting evidence to whether it's effective or not is always going to be, at this point, it's going to be tricky. And so what was the other part of your question? Was whether it was going to change in the future?
Yeah, I'm wondering if in the absence of,
she wants to know if it's getting dumped. I'm pretty sure.
Dumped.
Yeah, I mean, just in light of it, I mean, I've looked into this. There's been discussion about it. We know it was implemented without any actual evidence that it worked. We know that 4 of the elements don't have evidence to support their use. We know that they haven't spoken about things like directed pushing, which we know increases the risk of perineal tears. They haven't addressed things that actually do reduce perineal tears. And in light of all this, is there a possibility that we can just go, oh, crap, we've actually stuffed this up? And unfortunately, there's been the unintended consequence of, firstly, not reducing the rates of perineal trauma in the amounts that they had hoped, but also increasing episiotomy rates. And also, it's not you've done the research on the acceptability of this intervention. How do women feel about having the perineal bundle applied to their birth space?
In terms of the women, it varied considerably. So some were kind of, well, okay, it would have been nice to know, this was being done, and they appreciate that everyone's taking these efforts to reduce that sort of birth trauma. Others were, and I think we've got to sort of acknowledge the sort of, high rates of sort of sexual assault and sexual abuse in the community as well. So there were certainly a number of women who were kind of, well, I'd really like to have been asked about that because I'm, a survivor of sexual assault, and that kind of, touching of the perineal perineum and vagina and that sort of thing is really who does it in what context is really quite important to me. And that was sort of one of the big issues that came through in our most recent paper in terms of, okay, we need to have a conversation around this. And the consent process around the perineal bundle, because of that, needs to be really strong, and it currently isn't. And that was, we argued in that paper and argued in that webinar that was actually a foreseeable problem with the bundle. That we know that there is an issue in terms of consent, particularly around women who are survivors of sexual assault during consent during childbirth. That exists, and there's good evidence around that. And we know that there's a lot of evidence around, obstetric violence and how women perceive that as assault during labour and birth. And then into that, we drop this bundle with saying that for every woman, every time, with a fairly sort of, with a pamphlet and not much else to support it. And the impact on midwives was grossly underestimated by the WHO as well. They didn't respect the fact that probably upwards of about 40% of midwives were practicing a hands-off, hands-poised approach, which was effectively outlawed. Once the hospitals introduced the bundle, they all had to use a hands-on approach, which was, something that they clearly, as professionals, considered, rejected, and developed their practice around using a hands-poised or a hands-off approach, particularly around water births. I mean, from my perspective, the evidence around tears in water births kind of seriously calls into question the effectiveness of any of these bundles. We've known from large studies overseas that giving birth in water, which invariably uses a hands-off approach, the rates of perineal tearing are no greater than those women who give birth on land using a hands-on approach.
From a midwifery perspective, when you look at the current workforce shortages and the current job satisfaction, this plays into that massively too, because what we're saying is you have no autonomy over your practice and your experience. And the evidence doesn't matter. You will do as you're told. And that will affect whether your job satisfaction and whether you stay in the profession or not. We're seeing this now with all the changes. Midwives don't want to work in the system because it's not why they did midwifery. It's not the way, and they're not able to practice to their full scope of practice or in an autonomous way. This is not just about the people we're providing care for. This is about workforce as well.
Oh, yes. And I think in terms of longevity, well, we know, there are already some hospitals, not many, but a small number of hospitals that are cherry picking bits out of the bundle itself. There are a few that have ditched the rectal exam or have been less prescriptive about various elements of it. And, generally midwives have had a century of practice of being subversive. So we're very good at kind of working around the system when we need to.
Yeah, but that's the hard thing, right? Because often we get clever and we get tricky and we hide things. But then that's not good for evidence because it looks like we're conforming. So then we prove, this bundle's working, but we haven't been doing the bundle. And, we've really got to stop hiding what we're doing. We've actually got to be rebellious and going, we're not doing it. And this actually isn't working. But that's really tricky when you've got a mortgage to pay and you have to turn up to your work. Can I just ask, the study that you did on the satisfaction, was that just with the 20 people? Has there been anything larger on the perineal bundle satisfaction in Australia that's been
for the women? There was a qualitative study of their experiences. So that was with sort of 15, 20 women that we interviewed. Yeah. So it wasn't sort of looking strictly at satisfaction. It was really looking at their overall sort of experience of the bundle, sort of antenatally and intrapartum as well. And as I say, some women were quite happy with it. They were very appreciative of the efforts, but there were also those other women that really told quite some heart-rending stories of actually saying, no, don't touch my perineum, and midwives then saying, no, but I have to do this because it's part of our routine care.
I mean, again, this is not one size fits all, and it's about having the information to make the decision that's right for you. So if you're currently pregnant, find out what is happening with your care provider and at the place that you're choosing to birth. Get informed and make some decisions in your birth mapping, because it's not about consent, because consent implies that you're going to say yes. It's about making a decision and being, when would you be willing to have it, when would you not? It's super important that we have this information so that we can make better decisions in the moment that feel right for us, not only then, but afterwards.
And the thing with qualitative research is it's not like with quantitative research where you need these huge numbers to get a result. Like you keep researching until you reach a point of what we call saturation, in which case, we can make a reasonable assumption that you've captured the broad scope of women's experiences of that intervention. Nigel, is there anything that you really need to say about the perineal bundle that we haven't already fumbled through?
No, I think the biggest point is the fact that, it has been presented as the best and only available approach. And what we know, particularly from the research we've got from overseas, that it's not, that there are other bundles that are less prescriptive, that actually promote or use the physiology of birth, upright positions, really good sort of honest communication between midwives and women during birth, and, preparation antenatally as well, that produce better results. So I think we just need a better bundle.
And the bundle says,
call it that, the better bundle.
The better bundle. And the perineal bundle in it says that this bundle is not mandatory. Yet on the ground, when you spoke to the midwives, because you did a research study, you asked women, but you also asked midwives of their experience of the bundle. What were midwives' experience of the bundle in the sense that, like, the bundle says it's not mandatory, but is that what midwives experienced?
No, their experience was that they were essentially told that it was mandatory. And again, it comes back to they were told that it was to apply to every woman every time, unless they specifically said no. So it was an opt-out process. And also that there was no opportunity for any sort of discussion around the evidence base, around, okay, this is the evidence we're applying. This is why we think it's important. That was never discussed. The WHO have been very opaque about what evidence they used to underpin the bundle. We've asked them for a list of the papers and research that they considered and we're using to justify it. They've never applied to us with a list of research that they used.
Well, the leaflet only has like 24, 25 references, which is pitiful if you're trying to apply a 5-element bundle.
Yes. Well, of course, as I say, we've got randomized controlled trials that compared hands poised and hands off to hands on, and a Cochrane review of that, systematic review, and they all came to the conclusion that there is no difference in terms of severe perineal injury between the two techniques.
I had a look at this. I looked into this women's healthcare. It's called Women's Healthcare Australasia.
And WCHA. Okay. And who are they? And are there midwives on there? And are there academics on their board?
Well, they're a member organisation, so I have to say I'm not overly familiar with their structure, but certainly there are within their membership there are hospitals and representatives of midwifery and obstetrics there. But whether again, part of the problem with this is a lot of the membership, particularly from the midwife's perspective, are either clinical or managerial, and not necessarily going to have the experience and skills to assess research evidence and argue for and against it.
Yeah.
And I think, that the WHO said, well, the panel we used we had equal numbers of, obstetricians and midwives and consumers, but equal numbers doesn't equal equity.
And obviously the process hasn't been successful in the sense that they haven't used evidence to create the bundle. Okay. So 5-minute wrap up then of the perineal bundle.
Mel wants to drop. I loved.
Oh, sorry. Oh my gosh, I accidentally muted you.
I just love that you asked if it was going to be dropped because it has no evidence. But that's pretty much our whole podcast, right? Like I was like that with CTG. It's like, okay, can we drop them now? Like, can we just go back to basics? I feel like there's this real, what we're doing is not working.
Like I wondered, because it's a relatively new intervention, like 2018 is when they sort of started trying it out. We're at the point where it's not ingrained in practice like CTG is, where if we dropped it all of a sudden, clinicians would feel just ill-equipped to do their job. But if we drop the perineal bundle, at this point, we could go back to what we would do, whatever was happening before, right? We could just go, whoa, that was a blip in time. Let's forget we ever did that, come up with a better way of preventing the unfortunate situation.
And I think it's important to note that this is not a new recent conversation or discussion. We've been having this discussion now for over 150 years. I've got a paper here in front of me by a guy called Goodall from 1871, which is essentially a literature review of perineal protection strategies that he wrote in 1871 for a couple of years, 100 years before that. And he's putting up exactly the same thing. He's saying that, some people put their hands on the perineum. Some don't. Some point their fingers upwards, downwards. Some use packs. Some don't use, packs on the perineum, etc. And this was 150 years ago. So we've had these very, very sort of cyclic approaches. And I think probably, we've had the perineal bundle in now for about 3 or 4 years. It's probably a good time to take a step back. Okay, let's do some really good research around this. Let's really look at the evidence that what we've got for what actually works and what we know that kind of doesn't work. None of this needs to be applied strictly because, and I think one of the things that this always kind of bugged me about this was it denied clinicians and women the opportunity to have a discussion around what was, particularly for women, what was important to them and what they might like to use and what choices and alternatives are out there.
So if we do a 5-minute wrap up, what have we've learned about the perineal bundle is that there's 5 steps: warm compresses, hands-on approach to the birth process where perineums and babies are touched and manipulated during their exit, which relies on your back position, perineal assessments using rectal examinations for all women, and and the technique when performing an episiotomy. So do we know the numbers for how many hospitals have adopted it now? Because I had a look at the Women's Healthcare Australasia group, and quite a big number of hospitals are part of it. I don't know if we have numbers on.
I don't know how often they update their so we don't really know how many, and not only that, we don't know how many hospitals are using all of the bundle or only various parts of it.
Right. So there's 5 elements of the perineal bundle, and they say it's not mandatory, but midwives have experienced it as mandatory. The idea of the bundle is that women are supposed to be educated antenatally, but your research has shown that women don't recall being educated antenatally about the perineal bundle.
No, that doesn't seem to be happening.
Right. And it's anecdotally increased the episiotomy rate significantly.
Well, we've had a rise in episiotomy rates that coincides in the years that coincide with the introduction of the bundle itself. Okay. As yet, and we've got, we'll hopefully have a look at some of this data later on in the year, but we at the moment we don't have any evidence sort of directly associating one with the other. But it's a reasonable assumption at this point, I think.
Right. And I'm just going to read a line from a paper you wrote with Kirsten Small because I love it. This was in your paper, how a perineal care bundle impacts midwifery practice in Australian hospitals. And it was said in the paper, the introduction of the perineal bundle acts as an exemplar of obstetric dominance in Australian maternity care. And we recommend midwives advocate autonomy, women's autonomy and their own by using clinical judgment, evidence and woman-centered care, which is research language for the perineal bundle has further medicalized childbirth, and midwives should use their clinical judgment and evidence, of which there isn't any, to guide their practice, as well as obviously the women's choice. And so if we think objectively about the perineal bundle, it doesn't help with clinical care that is appropriate to women because it's a birth by numbers formula. And so it doesn't allow autonomy for women, doesn't allow autonomy for midwives. And although the bundle has wording which suggests that it should be done with consent and that it's not mandatory, the experience of midwives and women is that's not happening. It's being applied quite heavy-handedly.
Yes.
Okay, good. Yes. All those assumptions. All right. Final words, Nigel, about the perineal bundle. What do you really think?
Look, for me, it was a bit of a trip back to the future. We were doing this sort of thing, back in the 70s and 80s, and then we started getting it. And then I thought when we started doing the hands off and hands poised, and there was no dramatic increase in perineal injuries following that. That all seemed pretty good. And then I think, we got the backlash in terms of, it's all these midwives just doing stuff and we don't know what they're doing and it's not what we used to do. And I remember somebody commenting on the hoop trial, which is one of the big trials that looked at hands-on versus hands poised, and saying, we've been misled by this. We know instinctively that putting the hands on is going to be better. I'm thinking, well, actually, we're trying to get away from that sort of not evidence-based discussion. So I think, we really need to sort of respect each other's professional approach. There are probably some good elements in the bundle, and for some people it works well, but for a lot of midwives, let's say, who are legitimately practicing a hands poised approach and taking other approaches to managing perineal injury, their practice it needs to be equally recognised as appropriate.
Amazing. That's a wrap. Episode 19, the perineal bundle. I can also, other resources I can recommend are, well, the Midwives Cauldron podcast did an amazing episode on this. And I know I've mentioned their podcast before, but actually we're all midwifery sisters in solidarity, adding to the pool of information about this. So I think it's a great additional listen is the perineal bungle episode of the Midwives Cauldron. Rachel Reed has done a great blog post addressing a lot of these issues that we've discussed as well. If you're on the mailing list, you will get full text articles of the research papers we've been discussing today in this podcast, including some of Nigel's work. And Nigel will be with us.
Oh, can I add in two recommendations? I'm going to be biased, but I did a webinar for 2.5 hours and it's $10 and you can watch it, called Preparing Your Pelvic Space and the Lowdown on Pushing. So you can buy that, and it's not evident. My programs aren't evidence-based, but they do include pelvic floor exercises in a very holistic way. So you can check those out if you're pregnant as well. But Nigel is going to be joining us on next week's episode as well. That's what you were going to say before I cut you off, Mel. Where we dive into sterile water injections.
Awesome. That's a wrap. Thanks, Nigel.
See you next week, Nigel.
Okay, see you again.
Gorgeous.
Thanks for listening with us today. Don't forget to subscribe to our podcast on your favourite podcast platform and join our mailing list at melaniethemidwife.com. Mel sends out weekly emails with access to all the evidence we use in this podcast. You can find out more about Mel at melaniethemidwife.com and find out more about me, B, at coreandfloor.com.au. We can't wait to bring you next week's episode of The Great Birth Rebellion. Yeah!
Yeah!